Good afternoon. It's my pleasure to give this short presentation on lymphedema facts for vein practitioners. I would very much like to express my gratitude to Professor Giannassini and the other organizers of this meeting for the invitation to present to you. I think this is a very important topic for phlebologists because the lymphatic system and the venous system are so intricately interrelated with one another. So let me share a few of the many things that I think are important about lymphedema. The first is to talk about the problem of edema in general and to emphasize that edema comes in many so-called flavors. Let's remember that there are a variety of bodily functions and malfunctions that can result in an increase in overall fluid volume or a disproportion in the distribution of that fluid within the various compartments of the body. So as we approach a problem with as we approach a patient with edema, whether from a phlebologist or a lymphologist point of view, we need to think about where the edema is potentially arising. And in this category, of course, many of the factors are important, but I've highlighted a few that are becoming particularly important in the setting of a lymphedema presentation. And let's not forget that plasma oncotic pressure plays a central role, as we'll see in just a moment. I also want to emphasize that the lymphatics are the sole route of fluid reabsorption from the interstitium. Now, this is not 100% true, but it's about 99% true. There are some very specific settings in the body in which the normal function requires some venous reabsorption of fluid as well. But let's examine this in a little more detail. I think we're all familiar with the pioneering work of Frank Starling over 100 years ago, linking the various forces that govern fluid distribution across the capillary membrane. This is what we all traditionally have learned in medical school, and it is virtually correct, but there are a few additions that we need to provide, and that is based upon the more recent observation, unknown to Frank Starling at the time, of a barrier at the level of the capillary endothelium called the glycocalyx. And this hair-like projection from the endothelial surface into the lumen actually provides a hydrophobic barrier that in turn influences the fluid characteristics of this membrane and therefore the behavior of fluid in the filtration and reabsorption relationships. So here is the relationship as originally conceived by Dr. Starling, in which the movement of fluid from the arteriolar to the venular side of the capillary will produce phasic changes in hydrostatic and oncotic pressures, which theoretically would favor reabsorption of fluid at the venous end of the capillary. However, now that we understand the behavior of the glycocalyx, as well as the fact that interstitial fluid pressure, while very low, is not zero, we now have to revise our model and recognize that the oncotic and hydrostatic pressures that are actually prevailing at the level of the capillary will promote filtration of fluid throughout the length of the capillary, and therefore, by definition, all reabsorption of fluid from the interstitium is lymphatic in nature. So to show this a little more graphically, we see on the left-hand panel of this slide the vision that Frank Starling had of the behavior of the capillary in terms of filtration and absorption. And now we understand that, in fact, this process of filtration occurs throughout the length of the capillary, predicating the fact that reabsorption must occur through lymphatic conduits. Therefore, let's remember that while we think of the circulation as predominantly a muscular pump provided by the heart, arteries, veins linked together by a capillary network, we cannot forget the fact that the lymphatic conduit represents a portion of this circulatory relationship, and without the lymphatic reabsorption capacity, the circulation would fail within 24 hours because of the loss of fluid volume within it. The lymphatic system carries at any point in time about 2 liters of fluid, representing therefore about 40% or so of the cardiac output. And let's not forget that the lymphatic system is an immunovascular network. So it not only provides this vital circulatory function, but because of its relationship to the nodal structures that are scattered throughout its length, it actually subserves a very important immune function as well. To summarize, the lymphatics not only represent a transit for fluid from the extracellular space, they maintain fluid homeostasis. They're also very important in terms of nutritional balance because gastrointestinal lipid reabsorption is not possible without the lymphatic contribution in the gastrointestinal tract. And finally, as we've said, because this is an immunovascular network, the lymphatics vitally perform trafficking of antigen-presenting cells and lymphocytes to the lymphoid organs. The next fact I'd like to emphasize has to do with so-called primary lymphedema, that form of lymphedema that is presumably present on a genetic basis and not based upon an acquired defect in the lymphatic system and lymphatic function. But I want to be sure that we understand that in this context, primary lymphedema does not mean necessarily congenital. When we look at the primary lymphedema population, and this is a rare disorder in terms of the denominator of the population in the United States, we think there are perhaps 50,000 cases of primary lymphedema against a population overall of 350 million. But let's remember that congenital lymphedema, that lymphedema that is present at birth, represents at best 25% of this total. The major presentation of primary lymphedema is during adolescence and young adulthood, and traditionally we've called this lymphedema precox. We now understand that there are a variety of genetic substrates for lymphedema precox, and we continue to learn more day by day. There's also a very small but significant population of patients that we believe have primary lymphedema that have late onset after the age of 35. As we think about primary lymphedemas, increasingly the contribution of human genetics has been vital, and we now understand that there are at least 12 genomic mutations that are feasible to present as primary lymphedema. This list grows day by day, and it behooves us as clinicians to think more genetically than phenotypically, because one day understanding these mutations will help us to understand how to better care for these patients. My next fact is to emphasize the fact that the diagnosis of lymphedema chiefly occurs at the bedside, and it behooves us as clinicians to learn what the clinical characteristics of lymphedema are. This is not to denigrate the fact that there are very potent imaging modalities that are available if the diagnosis is in question, and these include radionuclide lymphoscintigraphy, more recently near-infrared lymphography, which utilizes chiefly ICG injected into the dermal space to visualize both the anatomy and the function of the lymphatics, and finally increasing utilization of magnetic resonance imaging utilizing gadolinium injection directly into the lymph nodes to be able to see the central vasculature, or peripherally to evaluate peripheral lymphedema. The next misconception that I would like to allay is that if one reads many of the vascular and general medical textbooks, there is still a prevailing notion that if lymphedema is pitting, it's not lymphedema, and if it's non-pitting, it is lymphedema. And both of those statements are incorrect. But most importantly, I would like to emphasize that lymphedema, like all edemas, begins as a pitting phenomenon in the affected portions of the body. However, it is true that with lymphedema, there is an inexorable progression to a non-pitting state as the tissues remodel and as there is a gel phenomenon that increasingly occurs within the interstitial space, allowing the excess fluid to be trapped within the gel and therefore to behave in a non-pitting manner. All of this is relevant as we look at the staging schema, the most widely adopted schema for lymphedema staging by the International Society of Lymphology, which, as you can see, as you progress through the stages, you increasingly lose the pitting quality as the physical changes of lymphedema supervene. Next misconception, one that I see very, very commonly, is that when a patient presents with lymphedema, the decision is to treat that lymphedema with compression. Now, I do want to emphasize that compression, as in phlebology, is vital to the management of the condition. But in the case of lymphedema, we first have to treat the lymphedema before we apply compression to maintain the benefits of treatment. So, stockings are, of course, vital to the long-term management of these patients, along with other compression interventions. But first, we have to invoke what is commonly called complete decongestive physiotherapy, that includes both a massage technique that manually stimulates the lymphatic circulation, and this can be done either in human terms with a lymphedema therapist, or increasingly we rely upon pneumatic compression devices that simulate the manual technique that is used by a lymphedema therapist and can in part take the place of that intervention. We rely on multi-layer bandaging to stimulate the clearance of the lymphatic fluid from the limb, and we utilize exercise to also augment that process so that ultimately we can achieve a nadir of limb volume, which then can be maintained by the chronic use of compression garments. I'd like to conclude by emphasizing the fact that lymphedema most certainly matters. Quite frequently, the lymphedema patient is encountering a response from the healthcare community that basically defines the problem as unimportant. Perhaps this arises because we recognize that lymphedema is not a life-threatening condition, but there is ample evidence that the presence of lymphedema very significantly deteriorates physical, social, and psychological functioning, and our ability to reverse this process is very central to the patient's well-being. Lymphedema has a natural history. The natural history is important, and it is very important, therefore, that we care for these patients in a manner that allows them to achieve the greatest degree of health that they're able to achieve. So with that, I'm going to conclude my comments, and I want to thank you very much for your attention.